Thank you, everyone. This is the title. And no disclosures, these are the funding agencies that we are very thankful. I'm going to talk about some of the amino acid PET imaging, which is not FDA approved. And starting with imaging of tumor-associated macrophages, and we all know that TAMs are a subset of macrophages that are abundant in gliomas, at least in an important subset of both high-grade and low-grade gliomas. And there is significant literature, especially from adult GBM, that they are a poor prognostic factor. So there is an opportunity to use imaging for tumor-associated macrophages, especially to monitor the response to treatment. And one way is to use iron and iron content of the cells as a biomarker for tumor-associated macrophages as a surrogate. This is a study that we did, and we did quantitative susceptibility imaging. These are the specimens with H&E staining and that we did, and also immunohistochemistry and imaging of the specimen with a high-field 9.4 Tesla MR, that we found a positive correlation between the iron content of the cells and especially M0 and M1 macrophages, knowing that M1 macrophages store macrophages and M2 ones, they provide iron to the tumors, knowing that the M1, M2 concept is an oversimplification. And these findings, we were able to corroborate that on clinical MR on 3 Tesla using quantitative susceptibility mapping. And so if you want to have a stronger signal, we can use thromboxetol, which is an iron nanoparticle that this group of studies from Stanford that they gave thromboxetol to adult GBM patients. And they did the image-guided biopsy, and they showed that the areas of the tumor that has thromboxetol kind of deposition, they have higher tumor-associated macrophage content compared to the areas with no deposition, and they showed that with immunohistochemistry, also with iron staining. And this is going to be applied in PNOC 025, which is a study that macrolimab is going to be used, which targets CD47, and we know that binding of this to human CD47 enhances tumor cell phagocytosis, and hopefully we would be able to use thromboxetol-enhanced MR to monitor the treatment and successful response to treatment. Shifting gears to amino acid imaging in gliomas, we know that amino acids play an important role in many cancers, including gliomas, and they contribute to cancer cell growth. So there are 2 important amino acid transporters, LAT1 or SLC7A5 and ASCT2 or SLC1A5. So amino acid PET tracers, they come in different flavors. C11 methionine, the oldest one, is a methionine analog. FET, which is a tyrosine analog, it has been heavily studied in Europe. Flucyclovine is a leucine analog, and that's the only agent that's widely available in the US because it's FDA approved in the context of recurrent prostate cancer, and F-DOPA, which is a phenylalanine analog. This is a paper from Petrino group indicating that amino acid PET imaging can be helpful in various stages of glioma imaging, from before having a confirmed diagnosis, for targeted resection or biopsy, and also for monitoring the treatment, both during the chemoradiation and also during the maintenance for follow-up. These are the papers from the Petrino group that are published over the years. And this paper on the lower left-hand side is about existing literature, mainly on FET PET in pediatric gliomas, showing that they can have a positive clinical impact. Just one example, on top you can see a patient with pilocytic astro that have some abnormal signal and restricted diffusion in the resection bed. On PET imaging, there was increased uptake indicating that this is recurrence. On the bottom, you can see a patient with medullo that shows increasing enhancement, however, without significant amino acid uptake. That was a case of post-treatment changes and was resolved by itself. Distinguishing progression from pseudoprogression is very important, that we see increasing enhancement on conventional MR, that will resolve by itself. It's really difficult to differentiate from these entities on conventional MR. This was our study in adult GBM, glioblastoma, that we used fluocyclovine PET to make this distinction on 30 patients, and we were able to show that there is significant difference in PET uptake in SUV max between the patient with true progression compared to pseudo-progression. They're significantly higher in true progression. And these are the ROC curves indicating significantly higher AUCs using PET metrics compared to advanced MR, including perfusion MR. And combining the MR and PET significantly increased the accuracy, AUC of 0.95. And we were able to do leave one out cross validation, and the AUC for that was 0.8. Just a few slides to show the concept. This is a patient with increasing nodular enhancement in the resection bed. And you see that the patient also has advanced MR perfusion. It's cold. The PET imaging shows significant uptake, and this is a patient with true progression with 60% tumor. We can see tumor beyond the extent of MR on PET. This is a patient with multifocal GBM that has the main bulk of the tumor is here. On the right temporal region, we see a little bit of signal abnormality even on FLAIR. It's very small. On PET, it's much larger, indicating that the extent of the tumor can be demonstrated on PET much bigger than MR. And also on the site of future recurrence, this is a patient that had this nodular enhancement that was partially resected. However, there is this PET uptake medial to this region, which subsequently on follow-up MRs showed progression, indicating that PET can call progression earlier, a few months earlier. And we are opening 2 trials at CHOP using fluocyclovine PET in low-grade glioma to monitor treatment and in high-grade glioma to differentiate progression from pseudoprogression. And I'm very pleased to see that on the PNOC trial, FET-PET is going to be used on select sites that have access to FET-PET. So I don't know how much time do I have? 3 minutes, perfect. So I'm going to briefly touch on our work with the bioinformatics group on pathway analysis of amino acid transporter genes in pediatric gliomas to determine the best diagnostic and diagnostic approaches. We're very thankful to the team, especially Adam Cray and Ron Jean and Kamal. Obviously, Adam Resnick always, we had his mentorship, and Ariana from the imaging group. And this is the kind of tree-based analysis looking at the SLC transporters that are important, and SLC1A5, which is one of the transporters of interest, continuously showed up in the analysis in multiple histologies. And so we looked at the human protein atlas, indicating that the level of expression is very low in brain parenchyma, which means that it's a good imaging target. The tumor is going to light up in the low background. And there is a significant expression, although variable, in different histologies in pediatric glioma. And we're able to show that SLC1A5 is a prognostic marker of overall survival in medullo and ependymoma. The higher the expression, the lower the survival, and also for PFS in low-grade gliomas. And also by gene pathway analysis, we're able to show that we can have an inference of intracellular glutamine pool by looking at the SLC1A5 expression. And then we expanded this analysis to lipid pathways by teaming up with Dr. Katie Wellen from Penn, which has significant expertise in lipid metabolism in the context of tumors, and specifically looking at the ATP citrate lyase and acetyl-CoA carboxylase. And so we showed that ATP citrate lyase and acetyl-CoA carboxylase, they have universally higher expression in all pediatric tumor types. And there is some differential expression, which I don't go into detail, but the idea is that now we are working on the cell lines, and we're trying to use inhibitors of amino acid transporters and also these lipid pathways in combination with glutaminase inhibitors or in isolation to see how they do, and also how we can monitor them with imaging. We're going to present this work at the SNO in detail in a month. So I'm going to skip this part. And thank you so much for your attention. And I know there is no time for a question, but please feel free to approach me during the poster session. Thank you.